Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. So in this video, we will be dealing with some basic respiratory physiology. So let's get started. So the first part about respiratory physiology is knowing about the different lung volumes and capacities. So note, a capacity is a sum of more than equal to two physiological volumes, and there are four volumes and four capacities. So number one is the tidal volume. So the tidal volume is the amount of air that moves into your lung with each quiet inspiration. Okay. Now, the amount, for example, you are sitting here, ideally, you are studying, you're watching the video, and if you just, so without any extra effort, the amount of air that goes inside your lung with each quiet inspiration is called as tidal volume, and typically it is 500 ml. The inspiratory reserve volume. Now, since you are sitting and you are doing a quiet inspiration, now the amount of air that you can inspire extra after that normal inspiration with extra effort is called as inspiratory reserve volume. Now, the expiratory reserve volume is what? So you are sitting there idle, you are inspirating and expirating normally. Now, after that normal expiration, the amount of volume that you can expire extra after that normal inspiration with extra effort is called as expiratory reserve volume. Now, the residual volume is the air in lung that is left after maximal expiration. So you have done that maximal expiration with your maximal effort, but there will be some amount of air that will be left there always in the lung, and that is called as the residual volume. The inspiratory capacity is now then what? Then your normal respiration, that is the tidal volume, plus with extra respiration, that is the inspiratory reserve volume. So that is called as inspiratory capacity. The functional residual capacity is the residual volume plus the expiratory reserve volume, that is the volume of gas in lungs after normal expiration. Outward pulling force of chest is well balanced. The chest wall is balanced with inward collapsing force of the lungs. The vital capacity is the maximum volume of gas that can be expired after a maximal inspiration. So first you do a maximal inspiration, which is what? Which is the inspiratory capacity, that is the IRV plus VT. And again, the maximal expiration, that is the expiratory reserve volume, okay? And that is called as the vital capacity of the lung. The total lung capacity is when you add the inspiratory reserve volume, the tidal volume, the expiratory reserve volume, and the residual volume. Then you get total lung capacity. Or you can also add vital capacity plus residual volume. Then you get the total capacity of the lung. Now, this understanding of this slide, this the different lung volumes and capacities is very, very important to understand many other diseases as well as other physiological mechanisms in respiratory physiology. So now, when you talk about ventilation, there is minute ventilation and then there is the alveolar ventilation. The minute ventilation is abbreviated by VE, which is the total volume of gas entering lungs per minute. So minute ventilation equals to tidal volume into respiratory rate under normal circumstances. Now that is called as the minute ventilation. So the alveolar ventilation, which is abbreviated by VA, is the volume of gas that reaches the alveoli per minute. Okay, so VA equals to the tidal volume minus VD and into the respiratory rate. So, for example, let's say now the tidal volume is 500. Now, among that 500, the 150 ml uh, of the air is left into the trachea and bronchi. Okay, now that air does not reaches the alveoli. So you just subtract from the 500 that 150 ml, then you get that 350, and that 350 ml is transported towards the alveoli in each breath. So when you multiply by the number of the respirations, number of respiratory rate, then you get that alveolar ventilation. So minute ventilation, you calculate everything, you do not subtract, and the alveolar ventilation is when you subtract, because there will be some air that will be left in the upper airways that will not reach the alveoli. Now there are some other lung and chest wall properties. So so because of historical reasons and small pressures, the pulmonary pressures are always presented in centimeter of water. Now, talking about the elastic recoil. Now, what is the lung elastic recoil? So it is a tendency for lungs to collapse inward and chest wall to spring outward. At functional residual capacity, the airway and alveolar pressures equal to the atmospheric pressure. Okay, and intrapleural pressure is negative, which prevents the atelectasis. The inward pull of the lung is balanced by the outward pull of the chest wall, and the system pressure is atmospheric. The pulmonary vascular resistance is at a minimum. That's how there is normal functioning of the lung. Okay, there is balance by the inward pressure of the lung and the outward pressure of the chest wall, and that's why there is the prevention of the lung collapse. The compliance is the change in lung volume for a change in the pressure. Okay, so change in volume, that is delta V, by change in the pressure, delta V, is inversely proportional to the wall stiffness and is increased by surfactant. Increased compliance means that the lung is easier to fill. Example, emphysema and older adults. Decreased compliance means the lung is more difficult to fill. Example, pulmonary fibrosis, pneumonia, ARDS, and pulmonary edema. So, so compliance means that how the lung expands and what is the curve that the lung again reverts back to normal. Okay, so the compliance is increased in case of emphysema and it is decreased in case of fibrosis. So hysteresis is the lung inflation follows a different pressure and volume curve when than lung deflation due to the need to overcome the surface tension forces in inflation. So whenever you are inflating, there is some surface tension which is maintaining that spherical shape. So surface tension, so just imagine a drop of water. So the tendency of drop of water is to always be spherical, is to always be a complete perfect circle. Now, the same tendency is there of the surfactant. Since the alveoli is lined by the surfactant, so whenever there is the tendency of surfactant to keep the alveoli that complete circle, then initially the effort is required. The effort is required to break that surface tension and expand the alveoli. That's why initially there is, while inflation, big effort is required to inflate the lung, whereas while deflating, there is decreased effort is applied while deflating the lung because there is additional work that is being done by the surface tension of the surfactant. So talking about the transpulmonary pressure, which is the alveolar pressure minus the intrapleural pressure. So the intrapleural pressure is negative during normal quiet breathing. The alveoli and lungs tend to collapse always. That is the pull inward or that is recoil, and they need outward force to keep the walls open, to keep the walls of the alveoli open. The chest wall tends to expand, that is spring outward. That is the alveoli and lungs always tries to collapse inward and the chest wall always try to expand, that is outward. And this creates a negative pressure in the pleural space. And this negative pressure sucks the alveoli open. So atmospheric pressure at 0 millimeter of mercury. So for example, the alveolar pressure is +5, okay, and then whenever the air flows out, there is the change of the +5 pressure. So while inflation, again, the air goes in, okay, and again there is balance between the negative and positive pressures, and that's how there is expansion, inflation, deflation of the chest cavity. So inflation is when the intrapleural pressure becomes more negative, the alveolar pressure becomes more negative and air flows into the lungs. Exhalation is when the intrapleural pressure becomes less negative, the alveolar pressure becomes more positive, and the airflow comes out of the lungs. So whenever the alveolar pressure here becomes more positive, which means that there is pressure which is acting towards the center, so that's how the air comes out. And if it becomes more and more negative, then it means that the alveoli is expanding. Now, here you can see in case of inhalation stage, that what happening, it is becoming more negative, and that's how the inhalation is occurring. Again, in case of exhalation, you can see it is becoming positive. That's why the air is going out. Talking about the alveoli and pleural pressures in different inhalation and exhalation stages, you can see the functional residual capacity. It increases in the inhalation. And again, while in the inhalation, the alveolar pressure becomes more negative. That's how there is the inward sucking of the air, and while exhalation it becomes positive. That's how the air escapes out of the alveoli. And again, while inhalation, the intrapleural pressure becomes more negative, and in the exhalation phase, the intrapleural pressure becomes less negative. One thing you need to always consider that the intrapleural pressure is always negative. It is never positive under normal circumstances. Now, this is the sequence of events that occurred in the inspiration and expiration anatomically. The inspiratory muscles contract and the thoracic cavity volume increases. Then the lungs are stretched. The intrapulmonary pressure drops to -1 millimeter of mercury. The air flows into the lungs down its pressure gradient until the intrapulmonary pressure is zero, which is equal to the atmospheric pressure. That's how inspiration occurs. In case of expiration, the inspiratory muscles relax, the thoracic cavity volume decreases, the elastic lungs recoil passively, intrapulmonary volume decreases, intrapulmonary pressure rises to +1 millimeter of mercury, the air flows out of the lungs, downwards pressure gradient until the intrapulmonary pressure is zero. Now, there are some typical features of the alveolar gas exchange. So there are large number of alveoli gives large surface areas for gas exchange. The single layer of flattened cells are there in the alveoli, which helps in the diffusion. Again, the substances for diffusion of gases. The oxygen dissolves in thin film of moisture on inside of the alveoli. This aids in the diffusion, surrounded by a dense network of capillaries. The gas exchange in alveoli. So when the partial pressures in the lungs are different than the partial pressure in the capillaries, the diffusion occurs. The oxygen diffuses from lungs into the alveolar capillaries during the inflation, and the CO2 diffuses into the lungs from the alveolar capillaries during exhalation. Now, during inspiration, what happens is that the oxygen concentration or the partial pressure of oxygen is more inside the alveoli than in the capillaries. So that's how there is diffusion of oxygen from high to low gradient, and the CO2 concentration is more in the capillaries than in the alveoli, and the CO2 exchange occurs from high to low again, that is from the capillaries towards the alveoli, and that is how ventilation occurs. The diffusion of oxygen towards the capillaries and diffusion of carbon dioxide towards the alveoli occurs. Thank you for watching. Keep studying.